We're good. Oh, that has some interesting. All right. Okay, I think we're good. I'm going to take the animations off of that slide real quick.
Ben, who's here, and Stephen and some of our other colleagues initially piloted this model at an Alameda Health System clinic in Hayward in 2015. June Tester, who's on our team, has been doing food as medicine work at Children's Hospital Oakland, and Recipe4Health was really able to formulate in the way it has thanks to former Alameda County Supervisor Wilma Chan, who died earlier this year. And she really put forward this model as part of a broader countywide anti-poverty initiative called All In. Next slide. So it's familiar to many of you that healthcare tends to really focus on downstream issues. Healthcare generally is not an anti-poverty program, but tends to focus on specific clinical conditions, things like diabetes or depression or hypertension, a lot of chronic conditions. And there's been increasing attention in healthcare to social determinants of health, like food insecurity and social isolation, which are the two that we're primarily addressing in this program, as well as other things like housing. And then there's also a real need to address structural determinants of health to change health outcomes. So things like policies and systems, structural racism, the way our economic system is set up, and so on. And so Recipe4Health is trying to be one of many efforts to move healthcare upstream in this way. So the program as it currently exists includes a few core components, or often we call them ingredients, given the recipe metaphor. So this is an integrative model of healthcare that's really situated within food as medicine as a broad frame that motivates a lot of different kinds of new models of care. Food as medicine really was one of the initiating concepts or efforts as part of the community health center movement in the 1960s. And so community health centers from that time have off and on been doing work to directly address food insecurity and other social determinants. So that's one piece of our work. Another is addressing chronic conditions, obviously highly related to food, isolation as well, and other social determinants. And then finally, working to advance health and racial equity here locally and beyond. And part of that work is clinical, and then part of it is also policy and systems change. So there's been a recent major exciting shift in Medi-Cal, California's Medicaid, to expand a bit what is covered as a benefit by certain Medicare and Medicaid plans. And so in Alameda County, Recipe4Health is now a covered benefit for people on Medi-Cal who are able to actually receive prescriptions for food and have it be covered by their health insurance. And Stephen is today in Washington, D.C. at a conference organized by the U.S. Department of Agriculture, trying to bring together agriculture and healthcare to do some of this national policy work as well. So Recipe4Health has 3 ingredients. Ingredient number 1 is a food pharmacy. Ingredient number 2 is what we call a behavioral pharmacy, typically in the form of a group medical visit, but also now expanded to some individual health coaching. And ingredient number 3 is training in food as medicine and related topics for the clinic staff in the sites that are implementing this program. So these 3 are getting all implemented within specific community health center sites, which are prescribing food to their patients and also prescribing participation in the group support setting, leading to the research component looking at how this affects individual patient and community health. So the first ingredient is the food pharmacy, and this is happening in partnership with Dig Deep Farms, which is a nonprofit agriculture organization growing food in the sort of eastern parts of Alameda County, Hayward, Fremont, some of the unincorporated areas there. And Dig Deep grows food in a regenerative agriculture way without pesticides, nutrient-dense food with a lot of attention to soil health. Dig Deep staff members, also known as pharmacists, are involved with home delivery of the food. So They are delivering food weekly to patients for either 12 or 16 weeks to their doorstep, kind of in like a home delivery, community supported agriculture sort of model. So everyone who participates in Recipe4Health gets the food from the food pharmacy. And like I just touched on, the food is grown locally, which has a huge effect on what the food is specifically. And Dig Deep is also a job training program for people on probation and people who've been incarcerated, being trained in permaculture agriculture. Next slide. So the behavioral pharmacy group visit program is provided by Open Source Wellness, which Ben co-founded in partnership with the clinics that we work with. And this program is really developed out of the question, how do we amplify and sustain behavior changes that will be beneficial for health? So we know that often, I'm sure many of us as clinicians or patients have had the experience of clinical care and being told that we should exercise more, eat better, try to deal with our stress, get some social support to help us with the changes that we need to make. These can be really hard things to do on our own. Often people come back and not much has changed. People maybe didn't have the support they needed or the resources they needed to make these changes. And so they're having the same conversation again with a clinician. The aim with the group medical visit developed by Open Source Wellness, similar to some other models, is to bring patients together, typically between 12 and 24 patients, who can have a range of chronic disease diagnoses related to physical and mental health. They come together, sometimes in person, but lately on Zoom, and have a weekly session with a health coach and with a clinician, and attend 12 weeks of weekly sessions where they're getting the opportunity to move, do some kind of movement together, nourish, which in person is eating together, but on Zoom, these are all people who are getting the food prescriptions and so are able to talk together about how to cook the food and at least talk about food. Connect, so have a small group peer support from other people who are working on making similar changes to their health, and then be, which is things like mindfulness practices and other contemplative practice. And so these are staffed in partnership between the Community Health Center and Open Source Wellness's health coaches who come into the clinic. And then the third ingredient that I think is somewhat unusual for these kinds of programs is a really robust food as medicine training for staff in the health centers. So this includes training in how to do universal food insecurity screening in primary care, some like training and workflow integration around making sure that the electronic health record is optimally set up to refer to this program and track food insecurity screening and that kind of thing. And then some substantial hours of clinical nutrition training for healthcare workers to be able to talk with patients about how food affects specific health conditions and how to benefit from the Recipe4Health program. And then finally, that clinics are really well set up to also be signing people up for CalFresh, the food stamp program in California. And up to this point, about 450 staff at community clinics in Alameda County have received this training. They typically get about 8 hours of training, so it's quite a big investment for the clinic. And staff have referred over 3,000 patients and growing every day to Recipe4Health. And these are patients with a wide range of health conditions. So people who are dealing with food insecurity across the lifespan, people with metabolic diseases like diabetes, people who are dealing with cardiovascular conditions like hypertension, depression and anxiety, people who are pregnant and coping with things like gestational diabetes, as well as a range of other conditions. Thank you, Yvette, for noting that people can get the closed captions, live meeting notes, and that I might be talking really fast. So Recipe4Health is across Alameda County. These districts are the county supervisor districts. Currently, it's in 5 clinics and continuing to grow, 5 different organizations that some of you might be familiar with. And we work really closely in partnership with the Community Health Center Network, which is kind of the overarching body for all of these organizations, as well as La Clínica de la Raza and a couple of others. And just want to highlight that the goal with Recipe4Health is really to bridge silos that tend to exist, in which healthcare is often very disconnected from all the great work that's happening around food and healthy food and food access, all the good work that's happening around soil health and land use, general work on making an economy that sustains and supports everyone, and then anti-racism and equity work. Often these are happening in separate conversations. And I can say that one of the most exciting things for me about working on this project has been having the chance to sometimes be in the room where farmers and clinicians and researchers and other people are all talking together about how do human health and soil health relate, and how do all of these different components connect to each other. Okay, Ben, I'll pass over to you.
Great. Thanks so much, Ariana. I'm going to talk a little bit about population served and the research methods. So we serve the vast majority of our patients are BIPOC. You can see 88% of our patients, and fully half of them speak Spanish as their first language. So we're really reaching a wide demographic of patients here. And they're also, they share a great deal of comorbidity. So nearly half of our patients have 3 or more of the chronic conditions that they're dealing with. And we've got some animations here, Lisa, if you could hit that. It's loading, huh? There we go. So you can see across a wide range of problems. In addition to that, about 1/3 have diabetes, and 10% have both depression and diabetes. All right, so I'm going to speak a little bit about the research methods here. First, I want to show, oops, can you go 2 slides ahead, Lisa? There we go. So I want to first start with this complicated data sharing diagram here. And I show this not so that you all can figure out just how we're sharing data together, but just to say that this kind of research is not simple, right? Like anytime we're doing research that is bringing together academic institutions and community partners and clinics and patients and all of this, it gets tricky. And so much of the services that we're working on is focused on the actual clinical work, bringing these services to patients. And then we're gathering as much data along the way as we can. So, you know, and then you can go back 2 slides, Lisa. In our methods, you know, some of the analyses are done in different ways. You can see in our analysis tab here, we're doing both pre-post analysis because our food pharmacy only group is getting survey data at baseline and then 4 months later after they receive their deliveries. In contrast, the group medical visits and behavioral pharmacy group is getting monthly data, monthly survey data, and so there we're doing mixed linear models. And then we're also comparing with propensity score matched control group, where we only have the EHR data. So on all 3 of our groups, food pharmacy only, behavioral pharmacy plus food pharmacy, and then propensity score match groups, we're getting EHR data. But then the timeline that we're able to do each of those groups varies slightly. So that gives us, you know, pre-post analyses in some cases, linear mixed models in other cases. And like I said, as much data as we're able to do. So the measures that we're getting run a very large gamut. So we're getting food insecurity measures, and then a range of mental health, including UCLA 3-item loneliness scale, the PHQ-9 for depression, and G87 for anxiety. A number of measures on kind of daily behaviors. So a very brief dietary screener about daily fruit and vegetable intake, 2-item physical activity, exercise is a vital sign measure, and also CDC's overall health, healthy days measure. Then from the EHR, we're pulling HbA1c, blood pressure, lipids, that kind of thing to get a sense of the impact on folks' overall health. And just beginning to look at utilization data. So shortly we'll be able to see the impact of some of these interventions on folks' hospitalizations, ER visits, that kind of thing. Now, because I'm a quant guy, I'm going to kick it back to Ariana for the qualitative methods here.
So this is a mixed method study, and we are in the midst of doing some longitudinal qualitative research as well. The sort of, I'm not sure what to call it, baseline, but we collected it over quite a period of time. So maybe not baseline, but early stage qualitative data that we've collected so far has included 39 interviews in Spanish and English. The majority of them have been with clinic staff across several of the clinics and with group visit plus food patients. We've also had the chance to interview some of the farm staff and group visit staff as well. And we're doing some ongoing kind of deep dive qualitative data analysis with this right now using reflexive thematic analysis approach, but we also have been doing a more rapid return of results, really trying to turn around the pieces of the qualitative data that are most relevant for program implementation and clinical practice using a method called lightning reports that were developed by some of Lisa's colleagues at Stanford to bring back to the program and implementation team. And I just want to dwell on this for a minute to say that some of our clinical and programmatic colleagues have said that this has been really useful to them and has been something that's allowed them to kind of see what is research for, and in particular, what can qualitative research do? And for me as a researcher, it's been a way to use data that when we're on more of like a 2-year publication timeframe turnaround, we tend to ignore, but in this context can use that like highly detailed implementation focused data and turn it right around and really kind of not waste it in the process. So that's been an ongoing process, just as we've also been doing very rapid turnaround of the quantitative analysis in a way that I think is not super common, but has been really necessary in this program to support policy work and program expansion.
Okay, I think I successfully advanced and unmuted myself. Awesome. Thanks, Ariana, and thanks, Ben, for kicking this off. And thanks to everyone who's listening. I really appreciate the deep dive into the program and then our research methods. It's nice to be here with you both. So I'll present some of the preliminary outcomes, and maybe just before I get there, I'll mention, I'm primarily a clinical trialist, although usually of behavioral interventions such as the one we're evaluating in Recipe4Health. And so building off of what Ariana said around the kind of constant communication between the evaluation team and the programmatic team on the ground has been a really exciting aspect of this evaluation, and to see how we need to be really flexible and creative about our evaluation, given that things are kind of always changing on the ground. So Ben mentioned that we're using propensity score matched control group because there was, at the time that we started, little appetite for randomization of an intervention like this. And, the propensity score is an option that we can use to create a control group so we can get a better sense of the improvements relative to a group who hasn't yet experienced the intervention. At the same time, Ben also presented to you a little bit about the data sharing and data access. We actually have to have a data analyst on the side of Community Health Center Network implement the model for the propensity score with help from a biostatistician who's kind of not behind the firewall. So it's presented lots of interesting complications. That being said, I'm not going to present the propensity score match control group today. We're actually just finishing up with creating our first match control group for patients who come from a clinic from the same system but haven't yet gotten Recipe4Health. And we still need to create that control group for some of the other clinics. So today you'll just be getting the kind of pre-post for survey data and a little bit of electronic health record data. Okay. And I will try to monitor the chat. I see, hi, Marilee, you had a question about the lightning reports, and I'm sure Ariana can drop that publication in the chat for you while we're talking. And I'm sure you actually know the person who developed it, so you can find out firsthand. Okay, so program reach. Let's see, I think in terms of number of patients who so far, this is as of September, data is a little delayed from actual implementation. Numbers of folks that have participated in the food pharmacy or the group medical visit. So you can see about 2,200 of the food pharmacy. Of those, 527 have participated in the group medical visit. And just as a reminder, everybody who's in the group medical visit also gets the food pharmacy. I'm not sure if that was clear up to this point, but everybody's getting food, and then a portion of patients, either as desired by them or as prescribed by their physician, or some shared decision-making approach, also participate in the group medical visit. Sorry, advancing my slides is not as easy as I thought. So that equates to about 37,000 bags of food that are being delivered to patients' doorsteps on a weekly basis. As a reminder, patients get 16 weekly deliveries of fresh produce that was grown by Dig Deep Farms. And although this used to be picked up in the clinic, now that the food is being delivered, we're much more sure of how much food patients are actually receiving. So the preliminary outcomes that I'll be presenting come from a subset of data, of course. So we have patient surveys, both from those who are enrolled in the food pharmacy only, as well as those who are participating in the group medical visit in addition to the food pharmacy. And as Ben mentioned, those who are enrolled in the food pharmacy, they get a survey at baseline before they get their first delivery, and then 4 months later, hopefully after their last delivery. And those in the group medical visit get surveys every month. Some of those surveys are used by open source wellness staff to kind of guide their treatment. And then we're also able to use those surveys for evaluation. We also have labs from the electronic health record for those who are in the food pharmacy and those who are in the food pharmacy plus the group medical visit. A little caveat with the electronic health record data, as with all electronic health record data, even though it seems like a big number, we actually, in terms of patients who have labs that we can use to evaluate in the baseline and follow-up periods, it's significantly less. It's a real challenge when you're not collecting your own data for a study, but you're using data that are available in the electronic health record. And then I think it was Ariana who mentioned that patients with lots of different conditions and kind of clinical profiles can participate in Recipe4Health. So here we have some information about patients who have pre-existing diabetes, depression, and anxiety. We'll be adding more subgroups as we go, and hopefully more data as we go, but we're also interested in understanding the experience of those subgroups. Okay. So of course, in Recipe4Health, we're interested in health outcomes, and as Ben mentioned, eventually healthcare utilization because of its importance for our policymakers. But as behavioral scientists and people interested in the multitude of benefits that come from engaging in healthy behaviors, we're of course interested in diet and also physical activity, especially for those who are participating in the group medical visit. So you can see we have about a serving increase per week of fruits and vegetables for those who participate in the group medical visit here. And then similarly, an increase in minutes per week of reported physical activity. And while it's, challenging to find clinically significant increases in health behaviors, a serving a week and around 50-minute increase of physical activity really are significant increases that we're seeing, and most of this data came from during the pandemic. So we think there were kind of some cards stacked against some folks in terms of making those improvements.
And for the diet there, Lisa, that's actually
Yeah.
servings per day, not servings per week.
Oh, I'm sorry. I think I was looking
Even
at
better.
the per week. Yeah. And I should say, Ben and Ariana, feel free to jump in as I'm going through the slides. So in terms of some of the qualitative work, we had a participant from the group medical visit who said, good things have happened because I also make my family, my husband, my 2 children eat healthier. And my husband sees that I'm going to Zumba, and I tell him, let's do Zumba. Come on, everyone. And we do Zumba as a family. And that's what I like. So that alludes to some of the ripple effects that would be fun to capture of patients participating in Recipe4Health. And a health coach says people who've never eaten vegetables in their life are now eating vegetables, which is exciting to see. In terms of diabetes, of course, this is an outcome we've been tracking, and changes as patients enter and new labs enter. So this is a very, very small decrease in hemoglobin A1C. We have a lot of anecdotal evidence from patients, health coaches, and providers that they're really seeing improvements in diabetes. So we'll be watching this very closely. One of the primary care providers said, I just met with a patient with diabetes yesterday who was able to stop one of her oral medications and then had been able to reduce her insulin a little bit. And I would expect that she'll be able to further reduce her insulin. A health coach said, the symptoms that come from diabetes have lessened. One of my patients, when she started, she used to have full body pain and her diabetes was really out of control. Now she's gotten to a more normal range and she doesn't have as much physical pain anymore. We are working actually with a master's student who's looking at our medication data specifically, so we can understand if Recipe4Health is having any impact on medications, specifically actually for diabetes. And that's really important for our policy partners to see. Okay, so I'll present some information on the food security data. So we use for those of you who are familiar with how to measure food insecurity, we use the USDA short form. So we use the hunger vital sign, the 2-item, to screen for food insecurity in the clinics as part of that implementation that Ariana talked about. And then once patients are either in the food pharmacy or the group medical visit plus the food pharmacy, we use the USDA short form at baseline and follow-up. And I will say that it's important to consider that the pandemic was going on in this time. And although we know that on an annual basis, the pandemic didn't have a significant impact on food insecurity levels, we know that there were very short-term impacts that perhaps you saw as captured in some of the pulse surveys that were done nationally. I'll also remind you that Recipe4Health provides produce only. This is not providing all food groups, and the produce is mostly vegetables. So I see these changes in food security actually as quite interesting because we know that salad alone does not solve food insecurity. You can see here at baseline that around 66% of the participants in Recipe4Health, according to the USDA short form, were food insecure, either with or without hunger. And then after 3 months, that decreased to 40% reporting food insecurity. So I think that's quite a significant finding, and I'm really interested in Ariana's data to help us understand what's happening during Recipe4Health, perhaps over and above the increased access to mostly vegetables. And feel free to drop in the chat your ideas. I think there's some interesting options there. Okay. Ariana mentioned that isolation or loneliness, social isolation or loneliness was one of the other outcomes or social determinants of health that Recipe4Health addresses. And so we saw a decrease in loneliness using our UCLA 3-item loneliness scale. And one of the patients in the group medical visit said, the group gives you a connection to the outside world, real people. Everybody is isolated. If you live alone, the group provides company, and it says there is someone outside to talk to. Okay. And then for mental health outcomes, so we see a significant reduction in the PHQ-9 score. So going from a score of 14.7 pre to 10.6 post is quite significant. This is, of course, among patients with moderate to severe depression at baseline. And you can see, I think 10 is consistent, 10 or below is consistent with mild depression. So hopefully moving some of those patients from a more concerning list of depressive symptoms to less concerning. Similarly, improvements among patients with anxiety using the GAD-7. All right, and some patient and staff perspectives again. So I felt depressed, and now I feel better. Says one of the patients. I see a lot of people come in with varying amounts of depression, whether it be clinical depression or just situational environmental depression. When you focus on your health and all other aspects, it can really help depression. So seeing some improvements there. So in terms of thinking about the implementation issues that we're seeing from the qualitative results, of course, we had a very quick pivot, as did many, during the COVID pandemic. And we definitely saw pros and cons of doing the group medical visit online or through Zoom versus in person. And also pros and cons of moving from a farmer's market style delivery or distribution of the produce in the clinic to home delivery. I don't know, Ben and Ariana, I know I can say a little bit more about the home delivery, but I wonder if, Ben, you want to say something about the pivot to virtual group sessions.
Sure. As you said, pros and cons. One of the things that we did find is that it lowered many of the barriers that our patients were facing. So folks who had trouble finding childcare or transportation issues like that coming into the clinic, it made it easier for them to get onto the groups. That said, we also have a significant number of our patients who have technological barriers, both lacking the technology to get on groups or lacking the technological literacy to be comfortable engaging over Zoom. And so we spend a significant amount of time orienting patients to Zoom, making sure that they have the kind of training to be comfortable coming into a Zoom environment, and starting at how to mute and unmute yourself, turn your video on and off, that kind of thing. But I would absolutely agree with Lisa there that there were benefits and drawbacks to both. We've also, I think, this is the Bay, and so we have always received questions like, when are you making an app for open source wellness, or when do you bring this type of coaching to a digital environment? And pre-COVID, our answer was always that the in-person element was vital. At a certain point, it became impossible to do it in person, and so we went with the next best thing. But I think there is a piece that is lost when we're not in person together, and when we have to make do with the virtual community rather than the live.
Yeah, thanks for adding that, Ben. Did you want to say anything, Ariana?
I'll just add one thing about the home delivery piece that I think may or may not be obvious, which is that the original plan pre-COVID, and we didn't really say, but this program started in about January 2020. So pre-COVID was really just a very blip before we had to switch. But the plan was that the food would be available at the clinic sites in kind of a farm stand format, and people would have a lot of choice about which food items they selected to bring home, and they would be able to have face-to-face conversation with someone from the farm about how to use the food and where the food came from. And in the small number of patient interviews that we've done, we've definitely seen that people are grateful for the food and very grateful for the home delivery. But the way it's set up, they're not able to make any choices about what they get. And there's also some confusion that I think comes from the fact that the food is locally grown and it's seasonal. And so only certain things can be grown at certain times of year. And, you know, the farms have planted fruit trees, but they're not fully mature yet. So they don't have a lot of fruit. And they're just factors that I think would have been more easily addressed in the in-person format. And that in particular for people who have had a lot of experience getting food at places like food pantries, where there's also not choice, not being able to select their own food options has some real downsides. So I know that's something that our farmer partners are really trying to think about how to work on longer term. And we've been able to give quick feedback about.
Yeah, thanks for sharing that, Ariana. And I love the ideas that you all are adding to the chat around how it addresses food insecurity. And I see your questions coming in, so I'll wrap up so we can get to those. I will just say that I thought for sure that our farm partner was going to want to return to the farm stand clinic distributions, but actually for them, it's a real trade-off having to staff those farmers market distributions in the clinic. And as we expand to so many clinics, that becomes really difficult, especially when you're staffing and you don't know when a Recipe4Health participant is going to come. So a lot of time goes into, you know, having the fruit, getting the fruits and vegetables there, and having a food pharmacist there, so that actually for them, they much preferred the doorstep delivery. So I found that really interesting, and I like it a lot better for patients, because I know they're getting it despite the trade-off with the choice. I think if we can solve that problem, we'll be in a good place. Okay.
For what it's worth, even before the R4H implementation, when these groups were running in person, we had some of the same problems with the food pharmacies in person, where if you came into the clinic in the afternoon, there weren't foods left, or there weren't foods you could choose from. And so some of these very same challenges that folks are having with the doorstep delivery still existed in person.
Yeah.
I think we often think that it would be different if we had this different implementation, and so many of the same problems come up there too.
The grass is not always green. And as
Exactly,
we head into
Lisa.
our heavy leafy green season, I know that people will be feeling that. Okay, I want to just share this. So, of course, a lot of the data I'm presenting has some limitations with regard to, you know, the self-reported nature of the data, the limitations, I'll say, in the lab data that we have available, and of course, the lack of control group, which we are solving. So that speaks to our future direction. So we're working hard at creating our control group so we can better understand the differences vis-a-vis a group that is similar but has not yet received Recipe4Health. We'll continue to explore changes in specific subgroups, as well as look at healthcare utilization, again, because of its importance to our policy partners, which is important for future scaling. And then we'll be continuing our evaluation as the intervention, the Recipe4Health implementation shifts and transitions a little bit with expansions in access as a result of CalAIM. Ariana alluded to this, but this is a policy change for Medi-Cal being able to pay for the food and health coaching that's provided through Recipe4Health, although it is a little bit of a different implementation. And of course, our kind of expanding state and national policy efforts. And before I unshare the screen and get to your important questions, I just really want to highlight that this evaluation takes a large team, and we have some wonderful partners at UCSF and Stanford, as well as Open Source Wellness and Community Health Center Network. So many thanks to all these folks. And I think we can stop there. I am never known for being on time, but I think we are on time for questions. Ariana, I know you are on your phone, and I don't know if you want to monitor the questions or how you want to do that.
I think I can take them. Yeah, I think there was one question. Oh, shoot. Edie, I think you asked a question about the cost of home delivery and gas. Was that your question?
Yes, sorry, just coming off mute.
Great. No, that's good. I actually have not been in any conversations where the cost of gasoline has come up, although I'm sure that Dig Deep is talking about it all the time. Ben and Lisa, have you heard anyone speak to that?
I have heard everyone speak to that and no one specific at the same time. So in our evaluations, I haven't heard dig deep folks talk about gas prices, although I'm sure it's affecting everyone. So I'm not sure that's a great question.
My impression at the beginning of the pandemic was that they were able to get some specific funding support and I think staffing support from sort of pandemic related funding sources. And so that in that way, some of the infrastructure around the vans and so on, maybe that was well timed and then they're able to use them permanently. Ben, do you know anything else about that?
No, I think it just speaks to, again, some of the challenges of, well, Lisa, you and I were talking earlier about the differences between like your RCTs where, I'm sorry, I have a fly landing on my face. This is hard to talk this way. RCTs are more academically located research where everything is a bit more controlled, and then research that's being done in conjunction with community partnerships or with activities that are more focused on clinical delivery. And then things come up like gas prices increasing, where it's going to dramatically shift the costs associated and the needs for funding. Just brings extra challenges, but also is I think what makes some of this research so vital.
If other people have questions, you're welcome to put them in the chat or to come off mute briefly and share out loud. Okay, in your new prescription program, you were planning to do home delivery, but now can't commit to it. Yeah, it does seem like a really hard time to start a home delivery program that way.
I saw, Rashida, you were asking about produce for the whole family or just the study participant, and then also about the group medical visit. Each bag contained, was it 10 servings of produce for the week?
So I thought it was supposed to be 10 pounds.
10 pounds.
Yeah, I think it's 10 pounds.
10 pounds. Oh,
Yeah.
Even better.
Yeah.
So, it's, I would say it's not, it's certainly not food for the whole week, but it is a substantial amount. And so the goal is to provide, I think, more than just the study participant. I can speak much more eloquently to the group medical visits, since that's my role instead of food pharmacy.
Can I add one thing about the food?
Please.
Which just that I know some produce prescription programs do ask people about family size and give people different amounts of food or household size depending on their household size. This program has not done that so far, I think mostly in the interest of trying to spread the available funding across as many people as possible, but that's something we've certainly talked about.
That's great, thank you. So during the group medical visit, we have a couple different pieces. So as Ariana said, it starts out with about 20 minutes of fun movement, kind of like a Zumba class, do a little bit of mindfulness meditation. And then we do an interactive lesson on health and wellness. And so these can be everything from how to eat healthy on a budget to getting more movement in your daily life, or setting boundaries, interpersonal boundaries in your relationships. And then move from that into about 45 minutes of small group health coaching. So this is where participants are in small groups of about 5 or 6 with other patients. And then each of those groups has a health coach and a peer leader that meet with them to help them focus on the goals that matter most to them.
Okay, I see 2 other great questions. One about, now I am having a hard time with chat on my phone. One about people who reported less food insecurity. Was it an oblique effect from some of the other ingredients in the study, like the group visit attendance? Does anyone have any insight into this presently?
Well,
Or
I thought there was a couple of really interesting contributions in the chat, if I can scroll back up. So Deborah said, vegetables in our diet help fill up our pots, our plates, our guts with concentrated nutrients. This gives a physical and emotional sense of security. I thought that was a really interesting insight. And then Ashley said, I could see how knowing that a food delivery to the home will happen weekly could impact food insecurity, regardless of it being mostly vegetables. I think that, other options are that increasing your connection with your healthcare team and potentially having the support of the group medical visit and others in the group medical visit could do a better job of connecting you to food resources in the community than you might have when you're not. So it may be impacted on top of or aligned with the delivery. And then Dig Deep Farms has a food hub. So they have other resources aside from the produce that they can connect patients with. And of course, when you get screened in the clinic, they're also connecting you with resources like, government resources, CalFresh, as well as other local resources. So I think there's a bunch of different avenues that we need to better explore. Of course, if it were up to me, there'd be thousands of questions on that survey, but we have to be very mindful of the fact that this is a real world implementation and not something we cooked up in an ivory tower. So we have limited, time with patients to ask them questions.
we have lengthy conversations amongst the team. Every time we want to add a question, we really have to talk about how important that question is and what we're going to drop instead, which is good, as it should be.
It is really good.
I'll just say about that too. I've been thinking about for our next stage of qualitative research, how to approach it. And one thing I've been thinking about is looking at some of these quantitative outcomes and doing follow-up interviews with people who sort of had the biggest response on some of these outcomes, and then people who really didn't see change on the outcomes, to try to understand more in depth some of what might be going on. So we may do that in the future. Okay, so a couple of other questions. Maria's question, so exciting to hear about this work. What types of adaptations are being made to group visits for the range of diverse patients that you're reaching? Are group visits being offered in multiple languages? Do you want to speak to that, Ben?
Sure. We are offering groups in English and Spanish right now. We're hopeful to offer them in more languages as we connect with additional clinics, particularly like Asian health services. We would need to increase the languages that we're offering groups in. And then the other adaptations, it's one of the pieces that that I love about this work. So we say move, nourish, connect, be, those 4 ingredients of the groups. Each of them is adaptable. And so the music that we use during movement and the nutrition lessons that we have and the foods included in the nutrition lessons and the way that the coaching looks, all of that differs based on the clinic that it's at and the population of that clinic and the needs of those patients.
I think Dig Deep Farms as well is really set up well to deliver the food program in English and Spanish. And then there has been some need for kind of more, particularly coming to the next question. So things like providing recipes, which they do, whether that can be done in other languages and which ones and what's needed for that. So some of the clinics have somewhat substantial, but not enormous Arabic speaking populations that are being served by the food program, but can't participate in the group visits. And even then, there are a lot of different kinds of Arabic are very different from each other. So Dig Deep hasn't had Arabic speaking staff. So this is definitely something that's what to do beyond English and Spanish is on the horizon.
I think, Lisa, you spoke earlier to the benefits of the home delivery versus in clinic for the food pharmacy. And that was something that I remember coming up for Dig Deep was having food pharmacists who were bilingual at each clinic site was a real challenge, right? And so you never knew who was coming to pick up food and if they would speak English, if they would speak Spanish, and having that kind of staffing was difficult.
Yeah,
this
really
is a
good
great
point.
question. Are the produce bags limited to fruits and vegetables? Is there any concern that Dig Deep would be unable to reach the demand? Sorry, just suddenly were lots of questions. Great. Meet demands with what is grown and produced. If so, would there be supplementation with frozen or canned fruits and vegetables? So I believe this has not come up in large part because Dig Deep has been growing tremendously and has at the beginning of the program had quite a small amount of land. I can't remember what it was an acre, maybe like 2.5 acres. And they have gotten some large land leases, including through the East Bay Regional Parks, where they're now farming on public land. And so I think that they are hopeful that they are going to be able to continue to meet demand as the program grows. But for sure, this is like one of several reasons that this program is not in every single clinic in the county.
And I think we probably need to wrap up, but I see Marilee and Rashida both asked interesting questions that we would love to know the answers to in terms of understanding the impacts of the produce prescription specifically. And Rashida, I can tell you that we are getting data on weight from the electronic health record, which hopefully, now that there isn't as much telehealth, we'll have more information on weight. We do not have information on smoking and alcohol intake from the EHR at this point. We did present some information on physical activity from the survey, but it's not the most robust questionnaire that of course we would like. If anyone's interested in adding on, and we are calling patients to ask all of these questions of those who are in the food pharmacy. There's always options to add resources to find out more.
If I can add one quick thing, Lisa, thanks so much.
Yeah.
We did in the early days, even before the R4H partnership, we tracked weight at our OSW groups, and we almost never found changes in weight. A few patients individually would, but on the whole, we did not see changes in weight, but we did see changes in other health markers. And so we think that the impact on the daily behaviors of health were far more important than the impact on weight. And Marilee, I love the stone soup analogy. I actually just gave a talk at International Congress for Group Medical Visits that was titled Stone Soup and Community. What was it? It was using the stone soup analogy for these groups.
Okay, I think we have to wrap up, and just want to thank everyone for coming. Really appreciate everyone's engagement in Q&A, and we're happy to answer follow-up questions. This is really a work in progress, so there's lots of possibility going forward. And I also want to mention our next Osher Center Research Seminar, which will be on November 8th at noon, from our colleague Gia Naranjo Rivera, and it's titled The Rights Framework, Radical Indigenous Transformative Evaluation and Storytelling, Evolving Methods to Liberate and Transform Racialized and Oppression-Based Stress and Trauma. So all are welcome to attend that, and we usually have the seminars once a month on Tuesdays at the same time. Thanks, everyone. Have a great day.
Thanks all.